Hello everyone and welcome to my channel. We have started the preparation for medicine subject. We have discussed the CVS chapter and also we have covered the pulmonology unit. Now we are starting the endocrinology unit. Okay, I will try to complete this unit in a single video. So starting from the endocrinology, we will be discussing the following topics, that is hypothyroidism, hyperthyroidism, hyperparathyroidism, hypoglycemic tetany, Cushing syndrome, Addison disease, diabetes mellitus, diabetic ketoacidosis, and hyperosmolar glycemic state. Okay, now starting from the first topic, that is hypothyroidism. Okay, so we are having a scenario that there is a 50-year-old female patient presented with increasing fatigue, lethargy, constipation, pins and needle sensation, and somnolence. On examination, skin is coarse and croaky white is present, and she is overweight. Another scenario is that there is a 45-year-old history of constipation, increasing fatigue, somnolence, voice change, increased feeling of cold, delayed relaxation of ankle jerks. What is the diagnosis, investigation, the treatment, and the complication options? So the classification of hyperthyroidism is that there is primary hyperthyroidism and secondary hyperthyroidism. In primary, we are having enlarged thyroid, Hashimotosis, that is 65%, iodine deficiency, drug-induced dysharmogenesis, and post-ablative and congenital and normal thyroid, that is spontaneous atrophic. The secondary hypothyroidism is pituitary or hypothalamic. The causes of endocrinology are congenital, that is dysharmogenesis, thyroid aplasia, iodine deficiency, and thyroiditis and iatrogenic causes may be present. The clinical features of endocrinology are weight gain. Of hyperthyroidism is weight gain, cold intolerance, constipation, dry skin, dry hair, alopecia, bradycardia, menorrhagia. The signs of hypothyroidism are brittle nails, thin skin, puffiness of face, yellowish of the skin, and thickening of the tongue. The investigations that are done for hyperthyroidism are thyroid function test. When the normal TSH is 0.5 to 5, then the T4 is 4.5 to 12 microgram per day, and T3 is 115 to 190. This is the normal amount of the TSH, T4, and 3. So in primary hypothyroidism, T3 decrease, T4 decrease, and TCH increase, that is gland is abnormal. In secondary hypothyroidism, T3 decrease, T4 decrease, TSH decrease, and pituitary gland. The tertiary hypothyroidism, T3 decrease, T4 decrease, and TSH decrease, which is tertiary hypothyroidism, hypothalamus failure. Okay. In secondary hypothyroidism, also there is pituitary gland failure. ECG is done to find the sinus bradycardia with small complexes. CBC is done for anemia. Serum cholesterol increase, LDH will be raised, creatine kinase raised, and serum sodium decrease. The treatment options for hyperthyroidism are replacement therapy, that is lifelong treatment with thyroxine, levothyroxine. The dose is 50 microgram for first 3 weeks, then 100 microgram for next 3 weeks, then 150 microgram as a maintenance dose. Thyroxine taken in morning so that food does not affect its absorption. Okay. Replacement therapy. The second option is increased dose of thyroxine is required in pregnancy, estrogen therapy, medications that increase T4 catabolism, and poor gastrointestinal absorption. The complications of hypothyroidism are ischemic heart disease and elderly levothyroxine, increased myocardial O2, angina, and emma can occur. And pregnant women, increased serum thyroxine binding globulin, and hypothyroidism can lead to miscarriage. So we have discussed the first topic of endocrinology, that is hypothyroidism, in which there is a scenario of 50-year-old female presented with increasing fatigue, lethargy, constipation, pins and needle sensation, and somnolence. On examination, she is having coarse skin, croaky eyes, and she is overweight. So what is the classification of hypothyroidism? It is primary and secondary. And what are the causes? These are congenital. And the clinical features and signs and the investigation options, these are thyroid function test, which is primary hypothyroidism, secondary hypothyroidism, and tertiary hypothyroidism. Then we will do the ECG, the CBC, the serum cholesterol, the LDH will be raised, and the creatine kinase will be raised, and serum sodium will decrease. The treatment options are replacement therapy, then the increased dose of thyroxine is required, then the complications are ischemic complications and the complications in pregnant women. Now coming towards our next topic, that is hyperthyroidism. We are having a scenario that there is a 25 years old unmarried female came to medical with complaints of palpitations and weight loss of 6 months duration. On examination, she is thin, anxious with fine tremors of hands. Another scenario is that there is palpitation, sweating and heat intolerance. On examination, her pulse is 120 per minute regular, fine tremors and her palms are sweaty. Rest of examination is unremarkable. Her FBC, blood urea and sugar levels are normal. So, the hyperthyroidism or thyrotoxicosis is defined as clinical syndrome which results from exposure of body's tissue to excess circulating levels of thyroid hormone, 5 times more common in female. The Graves' disease is an autoimmune disease associated with thyrotoxicosis and hyperthyroidism. It is most common cause of endogenous hyperthyroidism. The causes of hyperthyroidism are Graves' disease, thyroiditis, TSH, secreting pituitary tumor, and toxic adenoma. The clinical features of hyperthyroidism are weight loss, heat intolerance, fatigue, sweaty, pleuritis, palmar erythema, periorbital myxedema, systolic hypertension, tachycardia, anxiety, irritability, hyperreflexia, tremors, oligomenorrhea, infertility, impotence, hyperdefecation, diarrhea, and diplopia and lid retraction. The investigations that are done for hyperthyroidism are serum TSH level which will be low, that is 0.05 microgram per liter. T3 and T4 will be raised. TSH antibody may be present. Radioactive iodine uptake is checked, that is thyroid skin is positive in Graves' disease and toxic nodular goiter. Thyrotropin receptor antibodies are done which is positive in Graves and toxic nodular goiter. Diffuse goiter and ophthalmology is done. MRI is done and dermopathy is done. The management options for hypothyroidism are antithyroid drugs, that is carbimazole or propylthiouracil is safe in pregnancy, 40 to 60 mg per day for 3 weeks followed by TFDs, then 20 to 40 mg for 4 to 8 hours. Maintenance dose is 5 to 20 mg per day. Metamizole 40 to 60 mg daily is contraindicated in pregnancy and propylthiouracil 400 to 600 mg daily is safe in pregnancy. Then beta blockers are given. Symptomatic relief, tachycardia and tremors, propranolol 160 mg daily and nadolol 40 to 80 mg daily. The radioactive iodine is given in single oral dose which is contraindicated in pregnancy and ophthalmopathy indicated in patient more than 40 years in recurrence following surgery. The subtotal thyroidectomy is done if drugs fail and management of the ophthalmopathy is done. The majority of patients requires no treatment other than reassurance, but for symptoms of ophthalmopathy, following measures can be taken, that is steroid therapy, low dose radiation therapy, intravenous immunoglobulin, orbital decompression surgery, and methylcellulose eye drops to control dry eyes. So we have discussed the topic hyperthyroidism, its scenario, then the definition of hyperthyroidism or thyrotoxicosis, then the Graves' disease, the causes, the clinical features, then the investigation options which are serum TSH, T3 and T4, TSH antibody, radioactive iodine uptake, then the thyrotropin receptor antibodies, diffuse goiter, ophthalmopathy and dermopathy. The management options which are antithyroid drugs, beta blockers and radioactive iodine and surgery, then the management of ophthalmopathy. Now the complications of antithyroid drugs are hypersensitivity rash most common, agranulocytosis which is most dangerous, metamizole and cause arthralgia and fever, and PTO causes hepatocellular necrosis. The complications of antithyroid drugs are atrial fibrillation, hypercalcemia, nephrocalcinosis, osteoporosis, decreased libido, impotence that is decreased sperm count, and gynecomastia. Now coming towards the next topic, that is hyperparathyroidism. We are having a scenario that states that there is a 42-year-old lady presented with generalized body aches and pains, history of recurrent headaches, easy fatigability. At times she feels irritable and depressed, history of pancreatitis in past. On examination her BP is 140 by 100, ultrasound abdomen showed non-obstructing multiple calculi in both kidneys. So what is the diagnosis, investigation and the complication? Increased parathyroid hormone in blood pressure by PT gland. The causes are parathyroid adenoma which is most common in 80% cases, parathyroid primary hyperplasia, parathyroid carcinoma. The clinical features of hyperparathyroidism are painful bones, renal stones, abdominal and psychic hormones. The investigations are serum calcium which will be raised, serum PTH will be raised, phosphates will be decreased, alkaline phosphatases will be increased, urinary calcium will be increased, normal calcium will be 9 to 11 mg per dl, phosphate will be 2.4 to 4 mg per dl, Technetium-99 scan to localize parathyroid adenoma, neck MRI, neck ultrasound, and X-ray is done for phalanges, skull articular cartilages. The treatment or management options are that NSAIDs are given for pain, large fluid intake is done for hypercalcemia treated with large fluid intake, biphosphate temporarily treat hypercalcemia, and pamidronate and zoldytronate and aldronate may be used. So the surgical removal is the treatment of choice. Surgical removal of adenoma is done. The complications that develop are pathological fracture, UTI due to stone or obstruction, pancreatitis, renal failure, and peptic ulcer. So we have discussed hyperparathyroidism along with this scenario. Then we discuss the causes, the clinical features and the investigations, and the treatment options and the complications. Now coming towards our next topic, that is hypocalcemic tetany. We are having a scenario that there is a 38 years old man referred for cataract surgery, presented with spasm of fingers while checking his BP. Upon further examination, he was having positive Jost sign as well. So what is the diagnosis, investigation, complication and emergency treatment? The causes of the hypocalcemic tetany is hypothyroidism, pseudo-hypoparathyroidism, vitamin D deficiency, hypomagnesemia and chronic renal failure. The clinical features are numbness, convulsion, psychosis, abdominal muscular cramps, tetany, prolonged QT interval, renal insufficiency and acute tubular necrosis. Now, tetany is the increased excitability of peripheral nerve owing to either to low serum calcium or to alkalosis, in which proportion of serum calcium is ionized form is decreased although total calcium remains unaltered. The investigations that are done are serum calcium, serum albumin, that is, it is decreased calcium level if it's low, parathyroid hormone, ECG, serum vitamin D, and ABGs to exclude alkalosis. Life-threatening complications are cardiac arrhythmias and laryngospasm. The treatment options are treat the underlying cause, then acute hypocalcemia, that is cardiac monitoring, intravenous 10% calcium gluconate, calcitriol, magnesium chloride if associated with hypomagnesemia. Chronic hypocalcemia is corrected, that is oral calcium up to 3 gram per day and oral vitamin D, that is calciferol 50 IV 1 week for 8 to 10 weeks is given. Or control of tetany is done through intravenous calcium gluconate. Correction of alkalosis is done by intravenous saline, and maintenance therapy is given, that is calcium plus vitamin D supplements. So we have discussed the hypocalcemic tetany, then the causes, then the clinical features, and what is tetany and what are the investigation options that are done for hypocalcemic tetany, then the life-threatening complications, then the treatment options which are treat the underlying cause, then acute hypocalcemia is corrected, chronic hypocalcemia is corrected, control of the tetany is done, correction of alkalosis is done, and maintenance therapy is provided. Now coming towards the Cushing syndrome, we are having a scenario that there is a 3-year-old woman presented to 34-year-old woman presented to medical OBD with complaints of weight gain, weakness and backache. On examination, she is centrally obese, excessive facial hair is present, BP is 150 by 100 mm of Hg, and abdominal examination revealed purple striae. Now 20 years old man, headache, weight gain, depression on examination, obese, BP 140 by 100, skin is thin with purple striae, abdomen and leg, random blood sugar is 250 mg per dl. Diagnosis, investigation, treatment and complications. So what is Cushing syndrome? It is a term used to describe manifestation of the excessive corticosteroid due to any cause. Cushing disease is term used when excessive corticosteroid secretion is due to increased ACTH as a result of pituitary adenoma. Cushing disease is a result of pituitary adenoma. Cushing's disease is 4 times more common in female than male. The causes of Cushing disease are iatrogenic or exogenous administration of the glucocorticoids, endogenous cause, Cushing's disease, Cushing syndrome secondary to pituitary tumor, adrenal tumor, ectopic adrenocorticotrophic hormone production, that is small cell lung cancer, and medullary thyroid cancer or carcinoid tumor. The clinical features are non-specific, secondary diabetes, hypertension and osteoporosis is present, central obesity and moon fasces is present, spontaneous bruising is present, proximal myopathy, skin striae, acne, hirsutism and depression, and insomnia is present. The investigations are diagnostic investigations are dexamethasone suppression test, in which administration of 1 mg dexamethasone orally at 11 pm and then measure serum cortisol at 9 am. If it is normal, then it will suppress the cortisol. If the Cushing syndrome is present, then it will fail to suppress the cortisol. 24 or urinary free cortisol is another diagnostic test in which greater than or equal to 2 tests are performed. Reference range varies by age. For individuals greater than or equal to 18 years, there is 3.5 to 4.5 microgram per 24 or if diagnosed, then check for CAS by following test, that is plasma ACTH level, adrenal corticotrophic hormone, and plasma potassium level. Level is low in ectopic ACTH secretions. Then late night salivary cortisol can also be used for the diagnosis. Measurement of salivary cortisol at 11 p.m. and then if positive, then positive if above reference range. Now, what are the causative agent by measuring plasma ACTH? That is, plasma ACTH is low, then means ACTH independent Cushing syndrome. Means source is adrenal gland. Next step to confirm is ultrasonography, CT scan, and MRI. If plasma ACTH is normal or high, means ACTH dependent Cushing syndrome. Then source is either pituitary ACTH producing tumor or ectopic ACTH production. The management options are according to the cause. That is medical treatment. Those who take glucocorticoid etc. should be stopped. That is iatrogenic for ectopic production. Give ketoconazole. If transphenodal surgery, then transphenodal resection of the pituitary adenomas. Give hydrocortisone post-operatively as replacement therapy. Radiotherapy is done if surgery is not successful, and adrenal tumors removal laparoscopically is done. Ectopic ACTH producing tumors should also be removed if possible. If not, then give chemotherapy and radiotherapy. Octreotide can also suppress ACTH secretions. The complications of Cushing syndrome are hypertension and its complications, diabetes mellitus and its complications, increased risk of the infections and renal stones and psychosis. So we have discussed the topic Cushing syndrome, which is very major topic in the field of medicine. In endocrinology, we have discussed that scenario. Then what is Cushing syndrome and what is Cushing's disease? Then we discuss the causes, the clinical features, then the investigations. Then what are the diagnostic tests? These are dexamethasone suppression test, 24-hour urine free cortisol, late night salivary cortisol. Then what are the causative agents? Plasma ACTH level. Plasma ACTH is normal or high. Then management options, which are medical management, transphenodal surgery, radiotherapy, adrenal tumors, and then complications are studied. Now we will discuss the topic Addison's disease. Okay, now coming towards the Addison disease, we are having a scenario that there is a 40-year-old man recently treated for renal tuberculosis, presents with weight loss, anorexia, and progressive darkening of skin crease and buccal mucosa. Blood pressure is 60 by 40 mm of Hg and rest of systemic examination is unremarkable. Another scenario is that there is a 35-year-old female with 6 months history of anorexia, weight loss, generalized weakness. She has used anti-tubercular drugs in past. On examination, has increased pigmentation of skin and buccal mucosa. BP is 70 by 40 mm of Hg. The rest of systemic examination is unremarkable. So the definition of Addison is disease is that it is primary adrenal insufficiency, that is disease affecting adrenal gland, while hypothalamus and pituitary gland are normal, in which there is destruction of the entire adrenal cortex resulting in deficiency of adrenocortical hormones, glucocorticoids, mineralocorticoids, and adrenal androgens. The causes are TB, autoimmune adrenalitis, AIDS, metastatic cancer, bilateral adenectomy, hemorrhage or infarction, drugs, ketoconazole. The symptoms are weakness, fatigability, orthostatic hypotension, nausea, vomiting, diarrhea, anorexia, and weight loss, and skin hyperpigmentation. The investigations for Addison disease are general and specific. The general measurements are blood urea, increased electrolyte, blood sugar, that is decreased hypoglycemia, X-ray chest for TB, CT abdomen, RFTs urinary, and sweat sodium are increased. Specific investigations are serum cortisol is decreased, serum or swab for primary tubercle bacilli is done, plasma ACTH level is done, and tuberculin test for TB is done. The diagnostic tests are short ACTH stimulation test, in which short senectine test is done. Administer 250 microgram ACTH, then followed by taking blood samples for plasma cortisol. Normal cortisol increase then greater than 500 millimole per liter. In adrenal sufficiency, cortisol fails to increase. Imaging are done investigation for important to check out the cause, and chest X-ray is done for TB, fungal infections, and cancers. CT is done for abdomen. CT show bilateral enlargement of the adrenal gland in the patient. The complications are hypokalemia, generalized edema, hypertension, and fever, weakness, and contusion. The treatment options for Addison disease are intravenous resuscitation with normal saline to normalize the BP and pulse. Intravenous hydrocortisone is given. Replace corticosteroids, for example, hydrocortisone or prednisolone, and anti-tubercular drugs if still disease persists. So we have studied the Addison disease. the scenario for it, then the definition, the causes, the symptoms and investigations which are general and specific, then the diagnostic tests which are short ACTH stimulation test and imaging, that is chest X-ray, CT scan, and then the treatment options and complications. Now coming towards the diabetes mellitus, we are having a scenario that there is a 50-year-old obese male patient has polyuria, deteriorating eyesight and recent onset weight loss. His father and two sisters have had similar complaints for which they are being treated. So the definition of diabetes mellitus type 1 is that it is also known as insulin dependent diabetes mellitus, and it is autoimmune disorder characterized by absolute deficiency of insulin caused by beta cell destruction. Diabetes mellitus is chronic hyperglycemic disturbance in carbohydrates, lipids and protein metabolism. Disease may result from defect in insulin secretions, insulin actions and or resistance or both. Diabetes mellitus type 2, also known as non-insulin dependent diabetes mellitus, caused by combination of peripheral resistance to insulin and inadequate secretory response by pancreatic beta cells. There are type 1 and type 2. The type 1 is symptoms develop quickly, symptomatic appear after illness. The type 2 is hyperglycemic, develop slowly, and renal threshold for glucose rises. The clinical features for diabetes mellitus are polyuria, polydipsia, fatigue, weight loss, blurred vision, numbness, tingling of the hand and feet, and family history. The investigation options for diagnosis are criteria 1, criteria 2, 3 and OGTT. In criteria 1, polyuria, polydipsia and weight loss is present. Fasting blood glucose is greater than 120 gram per dl, that is greater than 7 millimole per liter, or random blood glucose level is greater than 200 gram per dl. In criteria 2, we are having the diabetes that are asymptomatic and the fasting blood glucose is greater than or equal to 126 gram per dl or greater than or equal to 7 millimole per liter, or random blood glucose is greater than or equal to 200 gram per liter, that is greater than 11.1 millimole per liter. The criteria 3 is that HbA1c is of greater than or equal to 6.5%, recently accepted criteria. OGTT is for diagnosis of borderline cases, gestational diabetes. Overnight fasting for 8 hours, sampling plasma glucose measured before and 2 hours after 75 gram oral glucose drink. Now, fasting blood sugar, random blood sugar, glucose tolerance test, glycosylated hemoglobin, urine RE, and lipid profile is done. Okay, normal and impaired glucose tolerance and diabetes mellitus. This is the table which should be memorized for the diagnosis of the diabetes mellitus. Okay, now coming towards the management options are, that is dietary management, that is low fat and low sugar, high starch, high fiber diet. Hyperglycemic oral agents are used, that is metformin, which is first line therapy for the type 2 diabetes. Only biguanide, that is decrease HbA1c by 1.5%. Mechanism of action is that it increases insulin sensitivity, increase peripheral glucose uptake, impair glucose absorption by gut, inhibit hepatic gluconeogenesis. Then sulfonylureas are used, which are first generation. These are tolbutamide and chloropropamide. Then the second generation are glipizide and glibenclamide. Then the alpha glucosidase inhibitors are used, which reduce glucose absorption. And thiazolidinone. Okay, it increases insulin sensitivity, and the agents rosiglitazine and pioglitazone are used. DPP4 inhibitor, that is gliptins, are used, which stimulate insulin secretion. Agents and sitagliptin, utagliptin is used. Exentide, that is increase insulin secretion, and the agent synthetic GLP-1 agonist is used. Insulin is used, that is subcutaneous injections given intravenously for emergency ketoacidosis and type 1 diabetes mellitus, that is 0.5 to 1 units per kg per day. So we have discussed the case of diabetes mellitus, the scenarios for the diabetes mellitus, and the definitions of diabetes mellitus type 1, diabetes and type 2. Then what is the difference between type 1 and type 2? Then we discuss the clinical features and the investigations for diagnosis. There are 4 criteria, that is criteria 1, 2, 3 and OGTT criteria. Then we are having these tests, that is fasting blood glucose, random blood sugar, glucose tolerance, glycosylated HP, urine RE and lipid profile. Then we are having the management options, which are dietary management, hyperglycemic oral agents, metformin, sulfonylureas, alpha glucosidase inhibitors, thiazolidinodiones and DPP4 inhibitors, exentide and insulin. Now coming towards the Topic diabetic ketoacidosis. We are having a scenario that there is a 20-year-old girl diagnosed with type 1 diabetes, history of acute abdominal pain, vomiting, and semi consciousness is present. On examination, she is dehydrated and tachypneic. BP is 100 by 70 mm of Hg. No neck rigidity and systemic examination is unremarkable. Random blood glucose sugar is for 80 mg per dl. So the definition of diabetic ketoacidosis is that it is hallmark of type 1 diabetes. It is medical emergency in which hyperglycemia is associated with metabolic acidosis due to greatly raised ketone levels. The clinical features are polyuria, polydipsia, dehydration, weight loss, nausea, vomiting, abdominal pain, and weakness. The investigation options are blood glucose is elevated, urine for ketone bodies is positive, urea, creatine, electrolytes are present, EBG's metabolic acidosis is pH is less than 7.3 and HCO3 is less than 15 millimoles per liter. Blood urea nitrogen anion gaps elevated than greater 1.2. CBC that is WBC is raised, electrolytes that is potassium is raised, ECG is done to exclude MI and serum osmolality is done. The normal range is 280 to 300. Now the treatment options for diabetic ketoacidosis are fluid replacement, insulin, potassium replacement, antibiotic if infection is present. Normal saline is given, that is 1 liter or 30 minutes, second or 1 or third or 2 or fourth or 4 and fifth liter or 6 hours. The dextrose water is used. It is given when glucose level is brought down below 250 mg per dl. Insulin is used, which is regular insulin. Intravenous loading dose of 0.15 unit per kg. Intravenous bolus followed by 0.1 unit per kg is continuous infusion. Potassium replacement is done. Give intravenous potassium 20 millimole in each infusion except in first liter. Monitoring ECG. Broad spectrum antibiotics are given like ceftriaxone. Vital sign monitoring is done. Orally BP is measured. Pulse input output record and serial EBG's tests are done. So we have discussed the topic diabetic ketoacidosis, its scenario, then the clinical features and what investigations are done. These are the investigations. Then we discuss the treatment options. These are fluid replacement, insulin, potassium replacement, antibiotic infection, normal saline, dextrose water, insulin, potassium replacement, and broad spectrum antibiotics are given. Now coming towards the last topic of endocrinology, that is hyperosmolar hyperglycemic state. We are having a scenario that there is a 70-year-old lady presented with fever, vomiting, and abdominal pain from the last 2 days. Since 3 months having polyuria and polydipsia. There is no history of diarrhea or dysuria. On examination, she is obese, drowsy, and dehydrated. BP is 110 by 80 mm of Hg and pulse is 100 per minute and she is febrile. The rest of systemic examination is unremarkable. Her RBS is 700 mg per dl and urine is negative for ketone bodies. So what is the diagnosis, the investigation, the management, the general risk to the patient, what is the prophylaxis? The clinical features of the hyperosmolar hyperglycemic state is that it is type 2 diabetes, mellitus, abdominal pain is present, and drowsy, dehydration is present. Dehydration, precipitating factors, DKA, dehydration, hyperglycemia, and altered mental function, and renal failure is present. The investigation options are severe hyperglycemia, that is blood sugar 600 to 2400, but ketones in urine, plasma osmolality greater than 310 millimolar per liter, serum bicarbonates greater than 15 millimolar per liter, ABG show normal pH, and normal anion gap is less than 14 millimolar per liter. The management options are fluid replacement, that is the mainstay of treatment in hyperosmolar coma. Normal saline as much as 4 to 6 liters in first 8 to 10 hours. Then once blood glucose reaches to 250 mg per day, then fluid replacement should include 5% dextrose water. Insulin therapy is given. It may be required to reduce hyperglycemia, but in lesser amount than intravenous. Require indicate initial dose of 15 units intravenous and 15 units subcutaneous of regular insulin is usually effective, with subsequent dose of 10 to 12 units, 20 units subcutaneous every 4 hours. Potassium replacement is done. It is less required as there is no acidosis, but insulin can cause decline in serum potassium, so it is advised to add potassium chloride to initial bottle of the saline if serum potassium is not elevated. Heparin is given as thromboembolic complications are common in hyperosmolar coma. Prophylactic subcutaneous heparin is recommended. So we have discussed the hyperosmolar hyperglycemic state, the scenario, then the clinical features, then the investigation options, then the management, which are fluid replacement, insulin therapy, potassium replacement, and heparin is given. Here we have got the endocrinology unit. In the next video we will discuss the rheumatology chapter and we will try to cover that unit in 2 videos. Thanks for watching.